first off, I'm Sharon Anderson, and I'm the president of Leiomyosarcoma Support and Direct Research Foundation. I'm also a 20-year survivor of uterine leiomyosarcoma. And today we have the great honor to host our guest speaker, Dr. Matthew Ingham. He is from New York Presbyterian Columbia University Medical Center. Dr. Ingham specializes in the care of sarcoma patients. He also leads several clinical trials for LMS, including those evaluating new targeted and immunotherapy treatments. So Dr. Ingham, thank you so much for joining us today.
Yeah, thank you so much for having me, and I really appreciate the opportunity to be here. And I've really had a great relationship working with some of the patient advocacy organizations, including this one. And I think you guys do really some amazing work for the patients and try to sort of help us interface and just try to make more progress. So I want to thank you so much for all the work that you're doing.
Well, thank you.
And I was going to go through maybe a little bit about some of the new directions that we're taking for the treatment of leiomyosarcoma. I think there have been a lot of exciting things that are happening, and this presentation is honestly a little bit more on the scientific side, derived from some work that we presented at ASCO, but I know that this audience may sort of appreciate a little bit more of that. So I'll just try to go through this relatively efficiently so we can have some more time to kind of discuss things.
Great.
So I think just to sort of take a step back here, what we're trying to do on the research side really is to understand a little bit more about the biology of LMS. And so, we're really trying to understand what genes are disrupted and what we can learn about it at the molecular level so we can identify treatments that are more targeted. We want to move away from chemotherapy as much as we can. That's really our strongest goal. When we look at this sort of diagram on the right, this is basically a number of tumors that were sequenced with genomics and with DNA sequencing, RNA sequencing, trying to understand, what we see in common and what we see is different among patients, so we can think about how to develop new targeted treatment approaches. And one of the things that we've learned is that most of the genomic alterations, they're in what's called tumor suppressors. There's kind of two categories of mutations that we see in DNA. One are sort of activating mutations, and one is loss or disruption of tumor suppressors. So, activating mutations, like, for example, we see commonly in lung cancer, those are relatively easy to treat with inhibitors that kind of turn those off. In LMS, one of the challenges we face is that most of the alterations are in tumor suppressors. So we kind of lose breaks, we kind of lose some of the policemen to keep the cells normal. So that's created a little bit of a challenge, but we're trying to work as hard as we can to find medication and sort of restore these tumor suppressors and get them working again. And then the other thing that we've learned about LMS is that it has a lot of sort of genomic complexity. So it has a lot of DNA damage involved, and basically it's trying to sort of replicate under conditions of really high DNA damage and stress. And that turns out to be something that we can actually target at a therapeutic level. And so basically, I think one of the most important breakthroughs in the last couple of years, and one that we're really trying to work on, is that one of the findings from these studies where we try to profile and understand the molecular basis is that LMS really has defective DNA damage repair. So, for cancer cells, they want to have some DNA damage, but they can't have too much because then the cells will still die. So, some mutations are good, but once it gets to a certain level, it becomes incompatible with the cells staying alive. And also we know that LMS has defective DNA damage repair pathways, and in particular, this pathway, which is called the homologous recombination pathway. And that pathway is really responsible for repairing double-stranded DNA breaks. And we've learned that LMS, seems to have a characteristic deficiency in this pathway. And that's important because that's something people have known about and tried to target therapeutically in other cancers like ovarian cancer, prostate cancer, breast cancer, where there's been a lot of success. So on the right side here, it seems that uterine LMS is particularly enriched in some of these homologous recombination defects, but we also see it in soft tissue LMS as well. And so kind of the importance of this observation, and this has really come out in the past couple of years, that there's a HR deficiency sort of phenotype here, is that we could potentially use a class of drugs called PARP inhibitors. And I'll show you sort of why that's the case. So this is sort of a little bit of a graphic. We also like our animations here. So it's a little bit of sort of a complicated topic, but the rationale for this basically is that all of our cells develop DNA damage every day, whether it's a cancer cell or a normal cell. And basically this normal molecule in the cell called PARP, it's responsible for binding to these sites of DNA damage to start the repair process. Now, just mention there's a certain type of chemotherapy called temozolomide that actually kind of induces this DNA damage in addition to sort of it normally happening. So basically, PARP is a normal molecule that helps to repair this damaged DNA. And what PARP inhibitors do is they trap PARP, this normal molecule, at sites of DNA damage. And when this molecule becomes trapped, it leads to two things happening: either double-stranded DNA breaks, which are very dangerous to the cell, or to something called a stalled replication fork, where the DNA is trying to repair itself, but it's not able to. And the reason why this is important is that this is actually what the HR pathway, the one I just mentioned, is defective in LMS. The HR pathway is really the preferred pathway for fixing this. And what happens actually is that in cancer cells that are HR proficient, meaning they have an intact pathway, they can fix this damage and just, the cancer cell will survive. But in cells that have this HR deficiency, which we now think is true of LMS, in addition to ovarian cancer and some prostate and breast cancers, so those cells are not able to repair this damage, and they just accumulate too much damage and then they die. And so really the concept here is that cells that have this HR deficiency, which we think is true of LMS, they should be sensitive to PARP inhibitors, because the PARP inhibitors basically induce a level of damage that is just not compatible with the cell being able to continue to live. And so basically we did a study that sort of tried to see if this was really the case, if this approach could help people. And so this was a study that was done in uterine LMS. I'll just mention that we think this probably is true of other LMS as well. And basically this is a clinical trial that was done for patients that had had one prior chemotherapy, and they were treated with olaparib, which is sort of the best known PARP inhibitor, together with a low dose of a chemotherapy drug called temozolomide. Temozolomide is an oral chemotherapy, but the dose that was used here is very low because we think we just need to induce a little bit of DNA damage with this drug. So that way we save the toxicity, we just use a low dose. And it's given just for 7 days, once every 21 days. So basically 7 days off and then 14 days, 7 days on, then 14 days off. And on the right side is just sort of a picture of the patients that participated in the study. So there were 22 patients, and maybe the most notable thing is that they had had a reasonable number of previous treatments. So most of the patients here, about 60%, had had 3 previous treatments before this. And what we found here, and this is mostly patients who had had previous treatment with doxorubicin or gemcitabine docetaxel, which are some of the more common chemotherapies that we use. When we normally get to that point, if we're thinking about standard of care, we're typically using medications like trabectedin or pazopanib, and those have response rates somewhere probably in the 8 to 10% range. So one of the things we thought was encouraging about the study is that the response rate was about 27%. But when a patient did have a response, one of the really encouraging things is that the response tended to last for quite a while. So, certainly we want to do better, but for the patients that had a response, the median duration of response was 12 months, was about a year. The overall progression-free survival, meaning basically how long the cancer stayed stable, was about 7 months. So this was encouraging because it looked like maybe this was a bit more active than some of the other standard treatments we have after chemotherapy, and it actually was quite well tolerated. Most of the side effects were reductions in the blood counts, which were mostly asymptomatic, but there wasn't a lot of other side effects, like fatigue or nausea. Those types of constitutional side effects were pretty uncommon. And then one of the other encouraging things was that there were, of the 22 patients on the study, there's 4 patients who are sort of still being treated beyond 2 years and kind of approaching 3 years. So, and these are all patients, that had cancer that was getting worse before the study. So there was a subset of patients that really did well for quite a long time. And then one of the other things that we're trying to do, one of the things we want to do for all of our treatments, is we really want to try to develop a marker that can show us what patients will benefit from the treatment the most. And so there was some work done as part of this trial to try to develop a test to identify these HR deficient PARP inhibitor sensitive tumors. And there's basically a test called this is just a technical term, but it's called a RAD51 Foci assay. You can see on the left here, the RAD51 is positive, and on the right, it's negative. And this is basically a marker of whether the cells have an intact repair pathway. And we think that if they don't have an intact repair pathway, they may respond better to this treatment. And that actually did seem to be the case. So this is a listing of all the patients who participated on the clinical trial. The ones in red are the ones that had a deficiency as defined by that test I just mentioned. And the ones in green, those ones were proficient. You can see here that some of the patients that were on this treatment for the longest time, it seems like most of them had this deficient HR deficient test based upon this this particular assay. So we're hopeful that maybe this, would help us identify patients that may benefit from this treatment approach, because, we want to, obviously we want to make the right choice for every patient, and we want to try to develop a test that tells us, well, this really could work for this patient, but maybe not for this patient. They should think about a different option. So hopefully this test will be something that helps us with that. And then I think I just want to mention some of the work that other people are doing as well. So, PARP inhibitors are kind of the first generation of DNA damaging inhibitors. There's some interesting studies that are developing now with sort of even newer drugs. And basically those are other newer PARP inhibitors. So on the upper right side here is basically some LMS models. These orange ones are soft tissue LMS, and the bottom ones are gynecologic. And basically we're seeing some evidence of activity from newer generation PARP inhibitors like talazoparib. And then there's also some other DNA damage approaches with what's called a CHEK1 inhibitor or a WEE1 inhibitor. You can see that all of the cells here had an R, which is a response, which means that at least so far it looks like from a preclinical perspective, some of these other DNA damage inhibitors may also be worth studying. And some of these are actually in the process of making it into the clinic, which is really exciting. And so I listed here actually just a few of the trials that are happening. So and the ones in orange are ones that are happening at Columbia, and the others are at other sites. But olaparib and temozolomide is going to be started in a phase 3 trial, hopefully in about maybe 3 months or so. And so, obviously we have to take with a grain of salt. The small study I was just talking about was only 22 patients. The way we can really understand if that's something that's promising is to bring it to a bigger clinical trial. So that's something that should be happening soon. And I listed here some other clinical trials, maybe just to highlight this third one down. So this is a PARP inhibitor, rusaparib, together with immunotherapy. That's certainly an interesting approach. And then there are some studies with just PARP inhibitors by themselves. And then there are some other studies down here, which are using some newer DNA damaging inhibitors, including some drugs that are targeting ATR and some that are targeting this other target called DNA PK. But I think the encouraging thing about this is that a lot of these trials are really LMS specific. They're not just for all sarcomas. They're really focused on LMS, which is exciting. And then I'll just run through a couple of other, new treatment approaches that I think are receiving some attention that look exciting. So this is another study that had some attention at ASCO this year. So we know that we sometimes use pazopanib, which is an oral medication. Basically, it works against shutting down some proteins that are on the surface of the LMS cell. And there's sort of a newer version. It's a little bit more broadly acting. So it basically will shut down a bit more of the receptors that are on the surface of the cell that we think may be important in LMS. And the name of the drug is called Lenvatinib. And so there was a study that was actually done in Japan looking at Lenvatinib together with Eribulin, which is a medication we think has some activity in LMS by itself. This was, something that was notable here on the right side. They're showing what's called the waterfall plot, where they show how much of the, what percentage of the cancer is shrinking. And this combination of lenvatinib and eribulin looked promising, where the response rate was about 28% or so. And this is something I think is going to be further studied. And lenvatinib is a targeted drug. Eribulin is more like a chemotherapy, but it's one that tends to be better tolerated. This here is another clinical trial that was just reported at ASCO that I thought was interesting. This is a study that we also worked on here at Columbia. So this is with a new medication called PTC596, which is an oral medication. And basically it kind of inhibits what's called microtubules, and that basically prevents cells from dividing when they shouldn't be. And it's given together with dacarbazine. Dacarbazine is a chemotherapy that we use later in the treatment of LMS that tends to be very well tolerated, which is one good thing about it. So dacarbazine plus PTC596 had a response rate of about 20% in a population of patients that had a lot of previous chemotherapy. It was also a phase 1 study, which means, in phase 1, sometimes we don't see sort of fully the activity of a drug because different doses are being used, including some doses that are quite low. But this was thought to be encouraging enough that it's about to open up as a phase 3 study as well. It's a randomized study with PTC plus dacarbazine versus placebo plus dacarbazine. We've actually treated a number of patients at Columbia with this, and one of the things that I think is really important about this is it is a very well tolerated treatment in terms of side effects. Patients really have great quality of life on this treatment, which I think we all know is really important. So here's just a quick listing of some of the studies that are going on with sort of targeted agents or maybe some targeted plus chemotherapy. So I mentioned the PTC plus dacarbazine. Lubrenectidine. This is kind of like a newer version of trabectedin together with doxorubicin. There's a couple of centers that are studying that. And then a few of the others that are maybe worth mentioning. So cataquetinib, this is sort of another newer version of pazopanib, but it's a tyrosine kinase inhibitor that is a little bit more broadly acting and does look promising. And then the last study I'll mention here is also sort of, I think, exciting because it's really trying to take a non-chemotherapy approach, at least in combination. So this is basically a metabolic inhibitor, ADI-PEG20. It basically tries to deprive the LMS cell of some of the metabolic nutrients that it needs, and it's given together with a lower dose of gemcitabine docetaxel. And it's something that was run out of Washington University. And the initial results looked encouraging, and this is also a study that's going to be opening up in phase 2 or 3 in the near future. And I'm just going to close out by just talking a little bit about immunotherapy. There's a lot of people out there that are really working to try to bring immunotherapy to LMS. I think that's one of our major goals. And I think the problem we have right now, unfortunately, is that some of the immunotherapies that work in other cancers, like lung cancer, melanoma, those being the Opdivo, the Keytruda, nivolumab, pembrolizumab, unfortunately, those have really not been enough to sort of jumpstart the immune system for LMS. And one of the problems we encounter in LMS is that something called the mutational burden, which is sort of how different the tumor is and how easy it is to get the immune system to see the tumor. The mutational burden is pretty low, which is a challenge we have to overcome. And then it's also worth noting that, LMS of soft tissue, it does seem to be a little bit more immune active than uterine LMS. Uterine LMS is particularly challenging because when we look under the microscope, we just don't see a lot of T cells or immune cells. This little chart on the right here was comparing soft tissue LMS versus uterine LMS, and it did seem to be the case that soft tissue LMS was a little bit more immune active. But I think there are some exciting approaches going on in the immunotherapy space. So basically, one of the things we know that we've known for a couple of years is that LMS has really a lot of immunosuppressive tumor macrophages. So macrophages are immune cells, but they're kind of bad immune cells. They basically prevent the good part of the immune system from attacking the tumor. And so there's really a thought in the field that we need to eliminate these bad macrophages and sort of get them out of the tumor so that the real immune system can come in and do its good work. And these tumor-associated macrophages, they really seem to depend upon this molecule called CSF1R. And so there's a couple of approaches that are going on to try to target CSF1R to eliminate these bad macrophages. And one of the reasons we think this is important is if you look on the right side here, they broke different patients, whether they had this CSF1R, whether they basically had these bad macrophages or not. And the patients with the bad macrophages, they did have worse outcomes. So that really tells us that we need to try to eliminate these macrophages. And in a similar note here, this is a study that was looking at another certain molecule called signal regulatory protein alpha. A little bit technical here, but this is a very similar concept. Basically, this interaction between SIRP alpha and CD47 is another way, basically, that the macrophages are sort of being dysregulated in the tumor cell. So there was an interesting study where they tried to inhibit this interaction between CD47 and SIRP alpha, and this was a sort of a nice study that showed that when we did that the primary tumor really did not grow at all. And also there was a much lower incidence of lung metastasis forming. So this was thought to be really promising preclinical data. And that's actually led to a clinical trial with this antibody that inhibits this interaction. So I think in the immunotherapy space, which is really another place we're trying to focus on here, there's a couple interesting approaches that are going on. So the first one is this drug called TTI-621, and that actually just goes back to the last slide I showed there. So that disrupts this CD47, and it kind of lets the good macrophages go after the tumor. Another clinical trial that we were doing here at Columbia is with this drug called APX005M. And the way we think this drug works is also by eliminating some of the bad cells in the tumor, the bad immune cells like the macrophages or the regulatory T cells. And then a third approach, all these first three approaches are really working against the bad macrophages, which we think are really important, is a DCC3014, which is a CSF1R inhibitor, together with avelumab, which is a drug like Keytruda. And then I listed at the bottom here, there are some other immunotherapy-based clinical trials going on that are a little bit less focused on macrophages. So there's the PARP inhibitor plus immunotherapy. There's another drug that works through what's called the STING molecule. So STING is actually a way that people are excited about going after STING because it can make immune cold tumors a little bit hotter. We think LMS is a little bit immune cold because we don't see a lot of T cells there. And basically STING tries to sort of activate the innate immune system and kind of overcome that immune cold environment. And then another study that's going on is with Ipi-Nivo, which is sort of a stronger immunotherapy, two immunotherapies together with a drug called Cabozantinib, which we think may help the immunotherapy work better. So those are some of the clinical trials going on in the space of immunotherapy. So yeah, I just wanted to mention that I think that, that we definitely made some progress in the last couple of years. And really what we want to try to do is really understand what is making the tumor grow at a sort of a biologic molecular level. So we can try to move away from chemotherapy and take a more targeted approach, either with targeted inhibitors or with immunotherapy. And I think that probably maybe the biggest message over the last year is that there really seem to be a lot of vulnerabilities in DNA damage repair pathways. So that seems to be a way that the LMS cell is vulnerable to treatment. Again, it kind of wants, it's helped by a little bit of DNA damage, but it has a defect in being able to repair the damage. So if we can sort of push it over the top, that may be really a targeted approach we can take to really define a more effective way of treating this disease. And we have some encouraging results from the initial study with the PARP inhibitor that I think support that. The other sort of directions that we're trying to take here, depleting these bad macrophages that we think are restraining the immune system. So depleting these tumor-associated macrophages, there's a number of studies that are trying to do that. And then the other one is just looking for other approaches we can take to restore some of the tumor suppressors that are lost. And then I'll just mention that I think at this past ASCO, there are some encouraging results for the Lenvatinib plus Eribulin, also the PTC 596 plus Dacarbazine, and then also, I guess this was now a year ago, the metabolic inhibitor plus gemcitabine docetaxel. So that's really exciting that those studies now are actually going into phase 3, which means that they've shown enough activity that they're worthy of study, that they're getting close to maybe really being approved to help patients. So I hope that wasn't too long, but that's sort of a quick overview, I think, of some of the exciting things that are happening so that we can, make more progress as soon as possible.
Oh, yeah, that was a lot of information. I'm excited about all the trials that are coming up. When I first started this 20 years ago, my journey, there were very few trials, very little research in LMS. So this is very hopeful looking at all this. And I am actually very excited about the macrophage studies myself, because we were part of collecting tumor tissue for Matt Vanderan at Stanford and creating a bank. And he did a study with metastatic LMS mice who had it in their lungs and did an anti-CD47. And it was very successful. So I've always been very interested in following that one along. Well, it looks like there's a few of them along. So that's really, really exciting. So we're going to open it up to discussions and questions. I've got one person has texted me their question because their chat is not working. And she says, do they know why this trial was successful? And one of the few years prior at Sloan Kettering, combining olaparib, excuse my pronunciation, with another chemo was not successful. And I'm not sure which trial she is referring to. I guess one of the first trials you were talking about with the PARP inhibitors.
Yeah, that's a good question. I'm not sure what previous trial that was. I think this trial with olaparib that I mentioned here, that to my knowledge, that's the only trial that has studied olaparib specifically in uterine sarcoma or in LMS in general. I think, one of the things that we learned, at least when we tried to think about how to pursue this treatment approach, was that it did seem like putting in the low dose of the temozolomide, meaning the chemotherapy part, it seemed that was really essential to sort of let the PARP inhibitor work. I think, we were trying to see, was there a role to just go with the PARP inhibitor olaparib by itself? But maybe one of the take-home messages was that, at least when we were studying this preclinically, it seemed like you really did need the temozolomide combined with the PARP inhibitor, because what the low dose of the temozolomide does is it kind of induces DNA damage, and then the PARP gets trapped by olaparib, and that may be really what's sort of required to make it successful. So maybe the reason is that depends upon the type of chemotherapy that we use, and that when we study this preclinically, it seemed like temozolomide was really by far the one that worked the best in terms of letting olaparib really work well.
Great. There's also a trial at Sloan right now, Sloan Kettering, with Dr. Mova, and I believe she's using PARP inhibitors, but she's combining it with a different chemo. Do you know which one?
Yeah, so her study is combining the same PARP inhibitor together with immunotherapy,
Yes.
which is also really exciting. I think, it's a little bit of a different sort of biologic thought. I mean, the thought there is that the olaparib may induce some damaged DNA that then may help the immune system see the tumor and go after it. So that's another really promising approach. That's a PARP inhibitor plus immunotherapy. And the thought is that maybe if we can damage the DNA more, it'll make the tumor more immunogenic and let the immune system see it a little bit easier. So I think that's also really exciting.
And I'm just going to ask my questions while people are typing in theirs. But how do you know if you might be a candidate for a PARP inhibitor?
Yeah, that's a good question. I think, one of the things that we're trying to do with our clinical trial, the olaparib plus temozolomide, is try to design a test that does help us predict which patients it's going to work for. So that test that I mentioned, the RAD51 test, it seems to be a good test for helping us tell whether the tumor really has this deficiency. And we're hoping to study it more, and maybe it could even be sort of what's called a companion test, which means that we actually use the test to help us tell which patients we should use that approach for, because it may kind of identify the tumors that really have this DNA damage deficiency. That being said, I think at least in the clinical trial in uterine LMS, most of the patients actually did have some benefit from it. There was only, I think, 3 or 4 patients of the 22 where they had progression at their first scan. So it was encouraging because we actually thought that most of the patients on the clinical trial had some benefit. And so I think our thought is that, and that was probably the same in soft tissue LMS as well. So I think that it's a hard question to answer, but hopefully we'll make some progress with this RAD51 test where we can do a test on the tumor and see if it really does have this DNA damage deficiency.
Okay, let's look at the chat box. Fahad says, very promising. I agree. Foci, which direction was the most relevant to uterine LMS treatment?
Sure. So I think of the clinical trials that I just went through, I think I think probably when we try to understand a little bit about soft tissue versus uterine LMS, I think probably the PARP inhibitors look like they are a bit more active in uterine LMS. Like uterine LMS has a bit more of a DNA damage deficiency, and one of the things about PARP inhibitors is with a place where they were first a breakthrough was in ovarian cancer, which is also a gynecologic cancer. There may be some biologic sort of similarities there, but I think for uterine LMS, that really the PARP inhibitor-based approaches are probably the most promising. And even beyond PARP inhibitors, there's another class of drugs that are right behind them that are sort of even newer and maybe even easier for patients to tolerate. So those are they don't have really good names yet. They're just letters and numbers, but those are drugs that are targeting these DNA damage proteins called WEE1, ATR, and CHEK1. So that's kind of the next generation. And those could potentially work even better. I think the important thing for us is that we really try to make the best decisions before we start a clinical trial, because a lot of resources go into that, and obviously on the patient side as well, to participate in a clinical trial. So I think what we try to do at Columbia, and I think what's really important, is to really make sure that when we get to the clinical trial stage, that we have the best treatment and the best dose, and that we're really giving it sort of the best chance for success.
Yes. Okay. Let's see. Jaeyoung Kim says, is there any data, it's a little different. Is there any data that suggests whether Eribulin or Dacarbazine is more effective on its own?
Yeah, that's a good question. So Dacarbazine is a drug that's honestly been around for a long time. And it's one of the oldest chemotherapies. It's similar sort of to doxorubicin and gemcitabine docetaxel. We've had it for a long time. And honestly, we tend to use Dacarbazine a little bit later in treatment because it is less effective than those other chemotherapies. It is very well tolerated. The interesting thing about Dacarbazine is there are some patients, maybe about 10% or so, that have a really, really good response to it. So it's not a high number. And the problem is we have no test to really use to detect who those patients are going to be. And unfortunately, a lot of patients don't have much benefit from Dacarbazine. That's why I think we're trying to combine it with other medications like the PTC 596, the clinical trial that I mentioned here, to make it work better, where it does seem like there's a lot better activity. Eribulin is actually not technically approved for LMS. Eribulin is approved for liposarcoma, which is sort of a different type of sarcoma. Eribulin has been studied in LMS, and it does have a little bit of activity. It looks pretty much equal to dacarbazine in terms of how likely it is to help a patient. But it's not FDA approved, so it's not common that we use Eribulin because it's, typically insurance won't approve it for the treatment of LMS. But from an efficacy perspective, they're pretty much the same. From a toxicity perspective, at least in my experience, dacarbazine is a little bit easier.
Okay, good. All right. Kathleen Bain. Hi, Kathleen. I always make her talk. What is the RAD51? How is the RAD51 test conducted?
Yeah, that's a good question. So how it's conducted, that's actually a pretty straightforward test, which is good because we want to develop tests that can actually, be used to help people in real time and be done and have the results, in a few days, not 5 weeks. And basically for this test, I just want to mention that we collaborated with Dr. Shapiro at Dana-Farber. He's really interested in DNA damaging approaches in all types of cancers. He really helped us with this clinical trial, and he actually is the one who developed this test, the RAD51 test, and they're looking at it in other types of cancer as well. But it's pretty straightforward, actually. It's just something called an immunohistochemistry test. So that means we just need one slide from the biopsy or one slide from the surgery for the tumor. They do a stain to see if they see these foci or not. If the stain is positive, that means the cell has the DNA damage repair mechanism intact so that it can probably repair the damage, and that means it may not respond to the PARP inhibitor. But if the stain is negative, that means that it may not have this repair pathway intact and that the PARP inhibitor may work. So long story short, it's an immunohistochemistry test where they just stain to see these foci. So it can be done in maybe 24 hours or so. It's like a very quick test, which is really important for us because that means we could use it in real time, in the real world. Not in the academic world. We can use it in the real world to help us sort of get results quickly and tell which patient may have benefit from the PARP inhibitor.
Great. Let's see. Lynn Hughes says, if non-uterine soft tissue sarcoma is more immunoreactive than uterine LMS, does that suggest that immunotherapy might be more successful mode of treatment than others for non-uterine LMS?
Yeah, so that's a good question. I think that it is true that when we look at just LMS, we do think that uterine LMS looks a little bit less sort of immune active than soft tissue. But unfortunately, when we sort of look at all cancers at large, they're both kind of in the, unfortunately, they're both on the less immunogenic side. But I think it does suggest that we may have an easier time activating the immune system for soft tissue LMS, because when we look under the microscope, at least based on that study that I showed there, we do see a few more T cells and B cells, which we think are important too. So it does look like soft tissue is a little bit more immunogenic, but it's still not quite immunogenic to have the existing drugs like the Keytrudas and the Opdivos work too effectively. So we need the next generation of immunotherapies like these macrophage depleting drugs, or maybe we need to give some of these Keytruda, Opdivo, in combination with another immunotherapy or a targeted drug.
Okay. Joanne Anderson, for a trial, how many previous chemos are okay to qualify? I would think that would be trial to trial, but perhaps you could speak about your trials.
Yeah, I think what we try to do more and more is have clinical trials be as inclusive as possible. That's something that the National Cancer Institute really wants to do. It's really, take out any unnecessary eligibility criteria, because we want to, offer clinical trials to as many people as possible. It used to be the case even when I was sort of, a fellow several years ago, that we would exclude things that really shouldn't be excluded, like if somebody, has had a certain number of prior lines of treatment or something else. Now, there's really been a shift in the field to take out all those unnecessary eligibilities. So I think for this trial, for the olaparib temozolomide trial, that's going to be opening up as a phase 3 trial. There's no limit on the previous treatment. So as long as it's going to be safe, to offer the treatment to a patient, the number of prior lines of treatment is not going to be an exclusion. Typically, it's only if they've received the same drug before. So, we don't want to ever really give somebody the same medication before. That's probably the most common exclusion. So for olaparib plus temozolomide, there's no limit on the previous lines of treatment, so that we can offer it to anybody. They do need to have some previous chemotherapy. We always want to make sure we're using these clinical trials in the right place. We don't want to necessarily always offer them before something we know may work better. But bottom line is that there's no limit for that one.
Great, thank you. And we all want to know what Farhat as asking, how can we get the RAD50, the RAD51 test?
Yeah, so I think what I would say about that, so this, we're hoping that we can use that test in the phase 3 clinical trial of olaparib plus temozolomide. So it did seem like on the phase 2 that it kind of, that it was the case that if you didn't have the foci, you had a much better chance of having a long response and a positive treatment course. But it was still a small clinical trial, so it was only 22 patients. So and the phase 3 trial, which is a larger trial with about 150 patients, we're hoping to use that same test to see if it's sort of really true. We hope it is, and the preliminary evidence is really compelling. But that being said, it's not yet sort of a clinically sort of a CLIA approved test. So when we do these new tests, to actually offer them to patients routinely, they have to go through a lot of validation and testing. They actually have to be approved by the FDA, and sometimes even at the state level by sort of the state regulatory body for labs. So right now this is still a research test, which means that we can do it as part of clinical trials, and hopefully, in a couple of years, if it doesn't look as promising as it did in the phase 2, it's going to be available for routine testing, just like, testing for, NTRK or one of these really common ones. But right now it's still a research test, so it's not clinically available.
Okay, thank you. That's what I had wondered about. Heather just wants to know if you have any diet lifestyle suggestions for LMS.
Yeah, that's another good question. I have to say, I honestly learn more about that from my patients than I myself know. It's something that I've really learned a lot about. And I think that, there is a lot of research that's kind of going into the whole metabolism space. I think probably a lot of you may know Dr. Van Tine. He's kind of leading a lot of research in the metabolism space, but other doctors as well, because we know that the cancer cells, they kind of break down sugars and different things in a different way than our normal cells. So if we can kind of really starve the cancer cell itself, that really is something that metabolically looks like it could work. But I don't know of anything I'm confident enough to say, and the other thing that we always worry about is sometimes we worry that our patients may get too restrictive in terms of some of their intake, and that may, sometimes not be as helpful. So I like to suggest that all my patients meet with a nutritionist, and they really tend to love that. And they, they really sort of get a lot out of that. And I think that I myself should probably see them. They come back so pleased with it, because I think that that's something that is really helpful. But I don't have anything that I've come across specific enough that I would recommend, other than being healthy in terms of diet and exercise, and having a good interdisciplinary team with a nutritionist, and going from there.
Okay, great. Thank
Sharon,
you.
can I just piggyback on the question about the RAD51? So,
yes.
Dr. Ingham, that means that we have to be on site to get that test done?
So right now that test is only being done as sort of as part of the clinical trial. So when this olaparib plus temozolomide study opens up for phase 3, we are planning to do that test for patients that are on that trial, because we want to see if it's indeed true that this test does predict who's going to have it work. The problem is that it's not a test that a normal sort of clinician can order, like they could order like a blood count test, that type of thing, because it's not yet an approved test. So it can only be done as part of a clinical trial. Hopefully that'll change in the future.
Okay, that makes sense. So does that mean that is it a precursor to being selected, or is it part of the selection process?
That's a good question. So right now it's not part of it's not required to be eligible for the trial, because we're not 100% sure if we don't want to exclude anybody, who may still have this treatment work for them and have a negative test. So it's just being used to basically tell how good the test will work, but it's not
just
required.
Just a collection of data on your part. Okay, got it. Yeah. Thank you.
Yeah.
Okay, when is this trial anticipated to start recruitment?
So this trial, one of the things that's neat about it was really a collaborative effort. So it was really worked on by a lot of doctors that take care of patients with LMS. So here at Columbia, we kind of led the process. We worked with Dr. Hensley from MSK, who really has been very much a leader in the LMS field, especially for uterine LMS, and some other physicians from other institutions. So it was really a collaborative effort, which I think is hopefully going to make it stronger. And it's being run through the National Cancer Institute. So it is, took a little bit of extra time. So we have to go through a lot of hoops and approvals, but it's basically to the point where it should be open and ready to start within, I'd say, probably in about 3 months. That's my hope.
Let us know, and we'll put the word out.
Thank you.
Yes. Okay. Mikem says, which of the clinical trials that you mentioned are the least cytotoxic, or least hepatic toxicity, have the least amount of toxicity. You mentioned temozolomide and, oh gosh, you're going to have to say the word for me.
Yeah.
I can't say it. Is that a good option?
Cabozantinib.
Thank you.
Yep. So I think that this is a good question. Let me think about it so I give the right answer. In terms of hepatic toxicity, I think that so cabozantinib, temozolomide probably would be a good option. In terms of global toxicity, I think we tend to find that a lot of the immunotherapy clinical trials, they tend to be a little bit less in terms of side effects than certainly than the standard chemotherapy. I will say that so although sometimes immunotherapy can induce hepatitis, that's pretty rare though. I think the immunotherapy clinical trials, those ones tend to have a little bit more limited toxicity. When we use some of the targeted drugs, then we have to be a little bit more cautious. I think, for example, pazopanib, we tend to sort of think that's an oral drug, that maybe it's a little bit less harsh, but I know a lot of my patients, do actually have a pretty hard time on pazopanib. So I think it's important to, to really look at the treatment. Sometimes it's not the case that, for example, an oral drug is more effective than an IV drug. I think for olaparib plus temozolomide, that was also very well tolerated, but just because the chemo was at a very low dose. So I think a lot of the DNA damage inhibitor trials, whether it's ours or whether it's the one you mentioned from MSK with the PD-1 inhibitor plus rusaparib, those are all pretty well tolerated because the DNA damage of the PARP inhibitors or the next generation, those tend to have mostly effects upon the blood cell counts, which we can monitor and we can fix those if we see a problem. So I think that maybe the best message here is that I think a lot of these treatments are actually quite well tolerated, and that's really what we want to do, is try to move away from some of the aggressive chemotherapy. The doxorubicin, gemcitabine, docetaxel, those are not easy treatments. I think basically all the clinical trials I mentioned are likely to be more tolerable than this.
That's good news. Tina says, hi all, I'm from the Philippines, but I have U.S. citizenship relative in the U.S. If we decide to push through treatments in the U.S., is this trial open to non-U.S. citizens? I have the BRCA mutation from Foundation 1HIM test. Thank you so much.
Yeah, I think, honestly, I think I would probably just try to connect with somebody at one of the hospitals that's near where your family lives in the United States. I think, oftentimes, and again, this shouldn't be the case necessarily, but, a lot of these centers require, a lot of clinical trials, they do need insurance to cover the standard part of the clinical trial participation. That being said, a lot of hospitals have programs that can overcome that if there's financial issues, which is what we want to do. The other thing I'll mention is that we do think that in patients with LMS that actually have a specific BRCA mutation, meaning they actually have a BRCA1 alteration, that may be a case where a PARP inhibitor by itself could be effective. There's definitely some information in the literature that if you do have the actual true BRCA mutation, that just the PARP inhibitor by itself without anything else in combination may be effective. And we have had some success getting those medications covered by insurance as a standard treatment, because I think that a lot of insurance companies will understand that even if this is not ovarian cancer, a setting where PARP inhibitors are approved, if a patient has LMS and has a BRCA mutation, we can often make the case to the insurance company that they should get this medication covered, olaparib or a PARP inhibitor, and so that's another approach. Basically, is not necessarily to do a clinical trial, but to see if the insurance will cover a PARP inhibitor because we can show a test with a BRCA mutation that suggests that it really should work.
Yeah, I've also been reading about a BRCA-like mutation. What is that?
Yeah, no, that really goes back to exactly some of the things I was mentioning before. So, what we think is that LMS, one of the sort of breakthroughs here is that these LMS cells, they have a deficiency in being able to repair their DNA. So basically, there's this really important pathway called homologous recombination, which repairs the most important types of DNA damage. And the most important gene in that pathway is BRCA. And that's the one that we understand the best. But to your point, there's a lot of other proteins and genes that also participate in this same pathway. So BRCA-like basically means they have probably a mutation in one of those secondary genes. It's not in the BRCA itself, but another gene in the pathway. And in our study with the temozolomide olaparib, we did actually find that some patients who didn't have a BRCA mutation, but they had a mutation in another sort of key gene, those actually really also responded very well to the PARP inhibitor. So BRCA-like basically means they have a mutation in sort of another family member in the pathway, not like the big ones, the BRCA, but another gene in the pathway.
Okay, great, thank you. I'm going to get to Farhat in a second, but Canary asked if hypothyroid is a common side effect of immunotherapy trials.
Yeah, I'd say it is one of the most common side effects that we see with immunotherapy. I try to remember the percent, I mean, off my top of my head, but I will say it's quite common. So we actually routinely test when people are on immunotherapy, either for standard treatment or for a clinical trial. We check the thyroid maybe once or a month or so in most of those settings because it's so common. Typically, we'll pick up that someone is developing hypothyroidism before they actually develop, symptoms like fatigue or constipation. Then we can, thankfully, hypothyroidism is a problem that's easy to fix by just supplementing back the thyroid hormone. We can really fix that quickly and keep patients on the treatment. But I'll say that hypothyroidism is one of the most common side effects of immunotherapy trials. The other ones, the other ones are probably rash and things like that. But thankfully, hypothyroidism, we can pick it up in a blood test and we can fix it right away.
Okay, yeah, it's fixable. Farhat?
Yes, so my question is, I'd like you to elaborate on your statement that you said the mutational burden is low for immunotherapy. Am I correct? Is that what you said? Not able to jumpstart immune system with immunotherapy? Most immunotherapy?
Yeah. So I think, immunotherapy, so these common drugs like Keytruda, Opdivo, they've really been a breakthrough for certain cancers like melanoma, skin cancer, also lung cancer. And one of the things those cancers have in common is that when we do a test, we find that they have a lot of mutations. So they have a high number called a tumor mutational burden. And what we found is that patients that have a high tumors that have a high tumor mutational burden, they're much more likely to respond to immunotherapy. And the reason for that is that the more mutations, the easier it is for the immune system to sort of see the cancer. And actually, the reason that melanoma has a lot of mutations is it's induced by UV damage. So there's really the UV sunlight creates a lot of mutations. And lung cancer, oftentimes there's a lot of mutations because of smoking induces a lot of mutations. So the higher mutation number, we know that is makes it easier for drugs like Keytruda, Opdivo to work. So, those drugs, we use them even in the first treatment for those cancers, even before chemotherapy. The problem with LMS is that the mutation number, it is usually more like maybe 2 to 5, whereas in, lung cancer, melanoma, it can be 20 or as high as 40. So in LMS, most LMS, and not all, this is why we have to test, because sometimes we will find some LMS that have a high number, but the average patient is closer to sort of 2 to 5. And so it just makes it harder to jumpstart the immune system because the T cells, the immune system, they just can't see the tumor easy enough. We need some other way of helping them see the tumor to fight it.
That's why we need the combination.
Exactly. We need some type of combination, or we need to take a wholly different approach, for example, depleting the macrophages, or we need to, develop something called adoptive T cell therapy, where we educate the T cells, we take them out of the body, we educate them, put them back in. But we have to move beyond the Keytrudas and the Opdivos because they're just not strong enough to jumpstart the immune system here.
Okay. I did the natural killer cell immunotherapy. It didn't work for me. Yeah,
and I understand. I mean, I think, that is one idea about how we could try to work in a different way to activate the immune system. But there is some evidence that NK cells are important, but it's at an early stage.
Okay. One more question. Do you have any data that shows that Asian people are at a disadvantage for getting results? Those of us who are LMS, ULMS, any data at all?
Meaning from immunotherapy or from
as a genetic standpoint for any kind of treatment?
Yeah, I mean, it is a good question because we know that, different people have different, even, sort of different small mutations in enzymes or things that process drugs or chemotherapies, et cetera, in different ethnic populations. But I'm not aware of any data that suggests, and this may be because unfortunately our field is a little bit behind other fields like breast cancer and looking at this. I'm not aware of any data that suggests that though.
Okay, thank you.
Yeah, I'm not either. I wish we did have it, but don't have it. Any more questions before we, Laura, you want to unmute yourself?
Can you hear me?
I can hear you.
Okay, I have one more question as far as the immunotherapy goes. I understand in LMS the tumor burden is low, but what if you have the PDL1 mutation?
Yeah, that's
Would
a good
that help?
Yeah, so PDL1 is really the target of a lot of these immunotherapies like the Keytruda, Opdivo. So I would say that the jury is kind of still out about whether if we see PDL1 testing positive in the tumor, whether that predicts that the immunotherapy is more likely to work. I would say there's definitely, some people do think that that is the case. Other people think that it's maybe not predict as well. So there's a chance that it could suggest that the immunotherapy is going to work better. But I would say the evidence is kind of conflicting. There's sort of differing opinions about that.
Thank you.
I have a question for you. Hi. Can you tell me what if you tested positive, ER positive and progesterone positive, and also have the BRCA gene too? Will the PARP inhibitor still work?
Yeah, I think so. I think those are sort of kind of separate issues. I mean, the ERPR, this is expression of hormone receptors, and so we do know that most uterine LMS will have expression of ERPR. There have been some studies looking at hormone inhibitors actually to see if hormone inhibitors may be effective for patients that have ERPR expression, but that should not in any way detract from the ability for the PARP inhibitor to work because they're kind of separate biologic mechanisms. So I don't think there would be any problem with that.
Okay, thank you.
Laura, did you want to ask a question? You had your hand up. Now we can't hear you. You may have to write it in the chat box. Yeah, you're muted. Okay. So
I may have answered that question directly. I think that question was related to, if we're in a situation where the tumor has a BRCA2 mutation, will the PARP inhibitor be covered by insurance? So, what I'd say with that, when we always try to get our patients the best possible treatments. And so unfortunately, sometimes a lot of our time actually is spent, working with insurance companies and even appealing or doing whatever we need to do to make that happen. I will say that there's enough evidence in the literature that PARP inhibitor, olaparib, for a patient with LMS with a BRCA2 inhibitor, our success rate for getting insurance to cover that has been pretty high. And sometimes it takes us, submitting some papers or, articles that suggest that it's going to work. But, I would discuss it with your doctor. And basically, I think a lot of us, for better or worse, we have a lot of experience working with insurance companies. And if they deny it, we can often appeal it. And we just, work as hard as we can to try to get it through.
okay, let's have like one or two more questions, and then we've got to let Dr. Ingham have his evening. So let's see, Heather writes, has there been any research into mRNA vaccine and sarcoma yet?
Yeah, that is a very good question. And I think that is something that, we definitely are hoping to move a little bit more into research with vaccines. There's been a little bit of work with some oncolytic viruses and some other approaches that are kind of in that family. I'm not aware of any mRNA vaccines yet, but my sort of most recent experiences with the DNA, damaging inhibitors, there's a lot of smart people in our field who are working on immunotherapy, and I will try to get a better answer to that question. Nothing is coming to the top of my head right now, but it is somewhere that we want to go.
Okay, thank you. Well, I just want to say thank you so much, Dr. Ingham. This has been a lot of information, and it's been a lot of very inspiring and hopeful information for us. So really, thank you very much for your time and your energy and your research. So yep, here comes all the thank yous in the chat box. But I also saw I noticed you had Count Me In.
Yeah.
Their little logo. And so we are part of Count Me In, and I'll talk to everybody about that later, but hopefully that's going to start pretty soon too. So, well, thank you again. Have a great evening, everybody. And we'll see you on the Facebook group. Bye.
Yeah. Thanks so much. Have a good night.